It drives drug adherence, and when you do that, you're able to get profound impact. The target population is anyone with chronic illness, particularly one in which multiple decisions need to be made every day. And so you can see diabetes as the poster child for that condition. But all these other conditions have had either complete research studies just on that condition, or they've been included in the other studies. And they're the common ones that we're all familiar with, ranging from cardiovascular disease, asthma, musculoskeletal, hyperlipidemia, hypertension. Sometimes there's symptoms like fatigue that may or may not have a diagnosis next to it, depression, etc. So I said it's a 6-week program. On the left is the kind of content. You'll see it's very different than the traditional disease management or even diabetes self-management education. It's not focusing on the disease. It's not focusing on what Fran was talking about, of how do you measure your glucose and how do you take your medicine and how do you know when to take it. None of that is really the focus. The real focus is on the self-management principles, how to set a goal and plan it. So every week the individual is taught how to set a goal, one that they have some degree of confidence, not too much confidence because then it's too easy, and not minimal confidence because they'll never accomplish it. Something that's a little bit of a stretch. They tell people in the group, or in our case, digitally inform people of it. And then they try to see how it works. So it's increasing your self-efficacy one little step at a time. They also often need relaxation techniques. Pain is a very common symptom, so pain management is often addressed, as well as problem solving. How to solve problems that are important. There's a number of supporting concepts that are maybe given 1 or 2 times out of the 6 weeks. The difference between the digital and the in-person is the similarities are that they are the same content. They're delivered differently, one in person and one online. They're the same theories, they're the same approaches. The fundamental difference is it's online and it's asynchronous. What that means is that the group never gets together at the same time. Monday, we have a workshop start. 25 people show up. If we want to, we can talk about how you get them to sign up and show up. But they show up, and they come as often as they want to over the 6 weeks. Typically, the first day or 2 of the week, they come on, they read the content of the week, they post their action plan, and maybe ask a question or 2 in a discussion board, have other people respond. The kinds of questions they ask, if they ask a question like, should I go on insulin? The community and the facilitator quickly say, that's not a question we can help. We're peers, we're lay people. But if they say, I have diabetes and I've never told anybody at work, has that happened to anybody else? How do they accomplish that? What do they do about it? Questions like that. Questions about their life. Questions about barriers to being successful. They post those questions, and then they come back a day or 2 later and see the response. And if they like that response, they continue that conversation. They post other things. So it's the same as the group in person, but it's actually different than the group because it's done asynchronous. If we have time, I'm going to do a demonstration, but I don't know if we're going to have time. So I think what I'd like to do first is just give you a little bit of the evidence, and then we can look at the clock and see if we have time. So there's been, as I mentioned, hundreds of papers on the digital, dozens of papers on in person, dozens of papers on digital. This is the one that's most recent. It was a 1,242 subject study out of Anthem Insurance. About 85% of the population was under 65, so 15% was above 65. It was a real-world study. They didn't restrict entry. All these patients had type 2 diabetes. They were offered an in-person or a digital program. 232 of them had the in-person, 1,010 of them had a digital program. And because of its size, because of the outcome measures that were there, we're able to make some really exciting conclusions. There are 3 papers that are written, and when you get a copy of this, if you want it, they're all there. The first was to look at the clinical outcomes at 6 months and at 12 months. As I said, the average age is about 57, 14%, 16% were above age 65. It demonstrated improvement in A1C. The A1C at the beginning was something like 8.04 and went down by 0.45. A modest improvement. But when they studied those individuals who were above 9, and it was a large enough sample size, they will demonstrate a significant decrease at 6 months of 0.93% and at 12 months of 1.27%, if your A1C was above 9. In some ways, you need to have a population that's sick enough so you can show an improvement in outcomes. They reduce depression, they improve medication adherence, they increase exercise, and more. But what was, I think, even more interesting is they did a detailed analysis, and this is now the research arm of Anthem, and looked at what happened to the healthcare utilization of the individuals in the program. They used what's called propensity matching, which is the closest to a randomized controlled trial that economists can get to, but it's not randomized. They take individuals who could have been on the program, meaning they look the same, they have the same health insurance, etc. They never enroll. They take at least 3 times the number of the subjects that they have in the study compared to the comparison. And then they identify 3 paid participants who were very similar to the subject. They then look at those 3 people's trends in healthcare utilization and cost compared to the single individual they're matched with. Then they mush it all together and get the result. I hope I didn't do any damage to that explanation. If you want more, I can try, or someone else can give you more detail. But the bottom line was they looked at that and were able to demonstrate at 12-month all-cause healthcare utilization decreased. This is in the year after the person completed the 6 weeks intervention. It decreased across the emergency department, the pharmacy, inpatient, and outpatient. What was most interesting, and perhaps not surprising when you think about it, there was no decrease in diabetes-related utilization or cost. I'll say that again.
I couldn't quite hear you, Neal. Could you say that?
I was going to say, there was no decrease in diabetes-related healthcare utilization or costs. These are all people with type 2 diabetes who don't yet have complications primarily. And if you think about it, you don't expect it to go down. If you have a population that becomes more engaged, if anything, you go up. They see the doctor more, they take their medicine more, they get their feet and their eyes and other things checked. But what was most important is it lowered the rate of healthcare utilization because of lower rates of comorbid conditions. So heart disease went down, kidney disease went down, musculoskeletal, sleep apnea, all of the hyperlipidemia, all of the associated comorbidities, or if you didn't have diabetes, your primary morbidity, were significantly decreased. And that was what allowed them to have a cost savings adjusted based on attributable to the intervention of over $815 per person in the 12-month post program. So again, no change in diabetes-related healthcare utilization, but significant change in the comorbid condition. So our program is being used in a number of different ways. It can stand alone as part of a disease management program, meaning that disease management is going on, people get recruited into it, they get their own disease management, however that's delivered, and then they might have our program for 6 weeks. It could be part of a well-being initiative that employers have, again, separate from the healthcare delivery system. It could be that it's coordinated with an in-person program. So throughout the country, there are thousands of programs going on in any given day, scores throughout the country, in small community-based organizations, not typically healthcare delivery sites, often senior service centers, area agencies on aging, or other programs where people over 50 or 60 come for a range of services. And some of our partners were working on how do you provide options to those individuals to go to an in-person version or to go to digital health. So Blue Shield of California has that program. For individuals they select who have chronic illness are enrolled, are offered the program by a partner for Blue Shield of California, a group called Community Partners, which is based in, called June 7th.
Is it a healthcare program?
I'll tell you in a second. Their program takes individuals from Blue Shield, calls them, talks to them, sees if they want a program. If they want the program, it's offered to them in person, digitally, or digitally. And then if they want digitally, then they come to us. It could also be integrated element of a chronic condition and population health program, and sometimes individual partners have condition management, digital therapeutic programs, and we add to it. So you tell me about the time that we have. We have about 20 minutes.
Well, let's get some questions
That's
first, and then we might turn to that.
If we have time.
Saves $815 a year. What,
So the first year, I don't have to.
first year, what does it cost?
300.
$300, okay.
I'm giving you an approximate cost. The cost is sometimes based on value-based. If people do better, we get paid more. If they do worse, we get about 300. I think the microphone is going to select.
What proportion of your targeted population were successfully enrolled in the program?
So you're asking the biggest question. So the answer is it's varied by partner. Up until 3 years ago, we didn't do any of the recruitment. We let the host organization do that. And a number of places just failed. They'd buy 300 or 500 seats and they'd fill 50 or 100. And then next year they'd say the program didn't work, we're not going to continue. So we recognized that we needed to do more.
Because I guess the next question is, are we seeing a selection bias?
Yeah.
Right.
So I think, so I'll answer two parts. One is, yes, you're seeing a selection bias. I don't know how to get around that with any voluntary program that someone signs up for. We recognize that you needed to do a different approach. And so some of our partners do all the recruitment themselves. Others, and Blue Shield is an example, a couple others, ask us or someone else to do it for them. The best way to think of it is a modern campaign for a digital intervention primarily should be delivered digitally. That means a telephone call or an in-person visit in the doctor's practice is not an efficient, effective way of enrollment. So we usually use what are called drip campaigns, where you'll give us a list of 10,000, 50,000, 100,000 eligible members, patients, employees. We then send a message crafted by us with your approval to those participants, those prospective participants, every week or every month or every 3 months over a period of time. You get about 1.5% to 2% of the target population to sign up for every one of those drip campaigns. So if you do it 5 times, you can get 8 to 10%. It's very hard to get much above that. And it turns out that those people who have the lowest self-efficacy on enrollment are the ones who do the best. But they also may be the ones who are least likely to sign up. So thinking about how do you use storytelling, how do you have authentic images of people just like me who went through the same self-efficacy, needing intervention, how it helped me, I can see it could help me, it helped someone over here, I can see how it helped me. It's really the secret sauce. And I don't think, if anybody tells you they're getting to 40, 50, 60% participation, they're probably talking about people who click on the site and then went away. But to actually get to the program and begin it, 1.5% to 2% per each drip campaign. And yes, you have a selection bias. I don't know how to get away from it.
I was wondering if the program in teaching resilience, and it sounds like things very similar to growth mindset that Carol Dweck.
Neal, could you just say who you are so people get to know you?
Neal Bohatson.
I couldn't hear it. Could you speak?
Sure. In teaching about resilience, which seems at least related to Carol Dweck's growth mindset, do you also get explicitly into things what are called loosely called social determinants of health, so particularly in Medicaid populations?
Yeah.
Maybe they had a job loss, their rent doubled, they're now on the street, and
Yeah.
all these other life disruptions outside of just kind of the lifestyle.
So I think it's hard to imagine that a digital program that you come to is going to go help you have a better food desert around you or give you a viable living wage. So that obviously is not what it's doing. But it is looking at a foundational question of if you increase your self-efficacy, will you be able to keep friends? Think about trying to make a friend and keeping that friend so you decrease your loneliness. Will you be able to handle the adversity that comes in front of you with a more positive attitude so you're more likely to succeed? And those are some of the, are you going to be more likely to sign up for the program, whether it's a arts enrichment program or it's a healthcare delivery or it's food stamps, because you feel like what you do matters. So I think at the foundation, whether it's digitally delivered or in person, whether it's ours or somebody else, programs that are based on increasing self-efficacy have that intended side effect, if you want to call it that, of influencing you across multiple parts of your life. If you said to me, why do we see an effect a year later? The A1C went from 0.97, lowered 0.97 to 1.27 at 6 and 12 months. It went better. Why is that? It's not because we were still there telling them what to do and giving them the dose of medicine. It was because they had changed their attitude. And they felt confident that they could set a goal and accomplish it. And that goal then led to better eating, led to taking their medicines, led to seeing their doctor.
Yes. I mean, personally, I think that's the explicit targeting of whether it's self-efficacy or Carol Dweck's positive mindset, growth mindset that educators are pushing, whatever reversal you're seeing in life, whether it's directly related to physical health or some other thing, you lose your job but can get back on track. Seems like that reinforcing that general, as you said, coping.
I agree. General coping. So one of the things that the CDSMP or the digital version, it doesn't require you to think about your health. The action plan can be nothing to do with health. The one that Dr. Warwick story she tells is she observed a woman saying, I want to learn 3 words in my native Alaskan tongue. And when asked why, because Dr. Warwick said, huh? Well, my grandma doesn't speak English and I felt disconnected from her. I'm learning 3 words. So for the first couple weeks, she learned 3 words every week. And by the 4th week, she then focused on what everybody else thought she should focus on, whatever that was. So if you fundamentally don't try to jam what you think is important as the leader, you're much more likely to help them to see what's important.
Would you like to play that video clip, or
I just have a question. If you're doing a digital format and you have patients that are on Medicaid and might be homeless and that population, who are your peers that are working with them?
Yeah, so we have just begun our first rollout in a low-income population in a federal qualified health center called Ultimate in Los Angeles. So I don't have experience. A lot of experience doing it in person, where it's been done with older people, with younger people, with people with varying conditions, whether it's HIV, et cetera. And I don't know how to answer the question for digital, to be perfectly frank. I believe that because of the nature of the self-directed choice over what it is that they're going to spend time, what they're going to think about, and what they're going to act on, I do believe that it will work. Give me a year and I'll tell you how it worked out.
you have a patient story on video, right?
No, I was going to, think I have that one set up. First of all, if you want to, Hattie will send out a PDF of the presentation, and on that will be links to a 3.5-4 minute video, which is a demonstration of the program, and a 3-minute video of one of our participants. What I thought I would do, again, up to the audience if you want to, is walk through a live version of the program.
Great.
So let's.
Thank you.
So wait a second to make sure it works. I think we're in good shape.
Yes,
So what-
stay near.
So this is a demo environment, so it's not true. Don't worry about that. No HIPAA violation. And again, it's the name of the program. It's HIPAA compliant. It does all the things it has to do. The person logs on with their email and password. We set this up before, and if it still works, we're in good shape. Okay. So let me just, so what I've done now is logged on to the site where, if you think about what a website is that's functioning like a digital therapeutic, it's a series of screens. It's a series of web pages. And on the left-hand side is what are called the navigation bars. Sometimes they're across the top. The design that we have worked on with seniors, with others, and with experts in design, have really looked at all of these questions, particularly for a population that's probably over 40, more likely over 50, who has one or more chronic conditions. How would they like to see things? So on the left-hand side, the navigation bar starts out with the homepage, which is where we are. There's a learning library. I'll go show you all of these. That's basically where the content is that you're able to learn in week 1, week 2. Discussion center, where you post ideas or questions for people to respond to. The action planning board, where you post the action plan. Today I'm going to try to walk to the mailbox and back, or I'm going to try to drink more water, or learn 3 words in native Alaskan tongue. Private messages is for the facilitator. Again, the facilitators are peers. They went through the program themselves in person in the past. They were then selected and trained in a 5-day training program to run in-person programs. Then they were trained by us, once they were successful in-person programs, to do the digital programs. Private messaging is where they can email back and forth between the facilitator and the participant, so the rest of the group doesn't see it. And celebrations is a place to talk about something that's good. One thing I didn't mention is it's anonymous, so we don't expect people or allow people to put their names. I suppose if they put their real name as their screen name, they can, but they're discouraged. We don't post pictures. We have avatars, etc. So I'm going to go to, good. We're good. Okay. Okay. So what you can see here is that these are the lessons that this particular participant, and one has done a number of these lessons already, but you can also see that the topics are listed. So there's an overview of the workshop, overview of self-management, how to manage symptoms, problem solving, exercise, healthy eating. These are all a range of pages that are within the program. So the goal is that the person spends a little bit, maybe 20 to 30 minutes of the 2 hours each week of their 6 weeks, learning certain content. The content typically is delivered to them in a weekly session. So I'm just going to go back to lesson 1. And we happen to be on page 13. So I'm just going to give you a sense of what it looks like. Individuals, now let's solve a real problem. So this is a section on problem solving. The person, again, is reading it themselves. The reading level is pretty low, maybe 6th, 7th grade reading level. The person is reading it, learning how to solve problems, and the like. And the example problems, common people with chronic conditions, enter a title for your discussion. So this is now helping them to put in a problem that they have that will go into the discussion center so that other people can respond to. The one I said, I've never translated work. Yes?
Do you have it in multiple languages?
No, it's only in English at this time.
Could it potentially also read to you?
Could it potentially also be in another language?
Or like read to you?
Oh, read to them.
So they wouldn't have to do any reading?
Certainly, someone else could read it to them. We did not set up a system. Our diabetes prevention program is actually done that way, where it's an actress reading a script, and this could be done that way, but we have not done that. So the person enters the discussion, what the question is, that then gets posted into their discussion board. Make sure you don't want to post it. I guess I'm in trouble because I don't want to post it. If I go back to the Learning Center, I could take a section on self-management. What does self-management actually mean? Acute versus chronic conditions, a vicious cycle. So this is the content that Dr. Lori has refined over those decades that are provided by the facilitator in person, but now provided by the digital application when you're in application. If you go to the discussion center, so you can see that there's a range of different topics. The number after each topic is the number of posts that had that particular activity. So eating, weight, goals, decisions, emotions, sleep. I'm just going to click on one of them and just sort of see the kind of things. Frustrated, getting people to respond in a timely manner. 2 people have made suggestions. I agree it's frustrating, I have to be patient. So this is just the beginning of a thread. We sometimes have hundreds, if not scores, many, many hundreds of these threads throughout the 6 weeks. Often have 6 or 8 to 10 people responding to it. And you can tell that a workshop's working really well when lots of people are having these kind of conversations. Private messages isn't worth looking at, it's just a way to communicate. And this is an example where someone had a successful action plan, the diabetes prevention program and onward. I'm not sure why they call it the diabetes prevention program. I'm so happy I made the commitment to DPP, but this is not the DPP program, so I'll have to figure that one out later. I completed my action plan, I took lesson 3. So people are posting no wine after dinner, so they're describing to others, and then the others are able to celebrate it with them. This is a list of the individuals. You can see that the people are using avatars, a little bit about the facilitator, what kind of condition he or she might have, participants' names, and the like. And then there's a section on resources that, again, Dr. Lorick has refined for the new person group that are just some tools. I wouldn't call them digital tools. They're delivered to you as a PDF. Getting online support, so you can write into our office and be able to answer questions for you. You can call into our support line and get information. If you're having a crisis, obviously you might not come here, but if you do, what should you do about it? Our facilitators are trained to be looking for people who are having a big problem. So if someone has suicidal ideation or anything that really is worrisome, we have arrangements and relationships with the host organization to be able to escalate that individual to a higher level of service. That's it. Any other questions or things you'd like me to talk about?
It's quite a bit of work that Neal has done in translating into a digital format what he's been teaching at UCLA for years and trying to make it accessible to a lot more people. So for instance, in our work with Bob Thurman and the California Department of Public Health, in trying to catalog where can people access the diabetes prevention program. It's a really important question, and unfortunately the answer is it is not ubiquitously available in an in-person format, and some people don't want to meet in person. It's a different psychology of who wants to meet online versus in person. So it's really an amazing piece of work that Dr. Kaufman has done with the academic institutions across California and beyond to try to make this more available to more people. So Neal, I just want to thank you for an outstanding presentation. Quite the dynamic duo here. I also just want to say that although we've been meeting on the second Monday of every month for several years here, next month it will be Wednesday, March 13th. Okay, so try to remember that. We will send you reminders, and no matter how many reminders we send, I'm sure some people will show up on Monday, the second Monday of the month, because we've created a beautiful habit of a lot of people coming together. So thank you to this dynamic duo for coming up from Los Angeles to share their incredible knowledge. What a couple, right? I mean, just in terms of Valentine's week, I have to say, what a beautiful love story that they're bringing this great news to so many patients
It's only
across
46
California.
years.
46 years.
Thank you all.
Thank you very much for coming, and thank you, James, Francine, and Neal, for your presentation today. We look forward to take these tools that we learned here today and perhaps use them tomorrow. Thank you for coming. Drive safe.